First of all, I'm going to start with a land acknowledgement, and I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, and Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to enrich our vibrant community. So I am simply delighted to introduce our speaker of the morning, Dr. Nabeela Nathoo. Norman couldn't make it today, so I was excited to step in. I've known Nabeela for a really long time, ever since she was doing her PhD in neuroscience and imaging at the University of Calgary. Of course, in the greatest disease of all, CNS inflammatory disease and MS. From there, she did her medical school at the University of Calgary and then came to the University of Alberta, where she completed a neurology residency. And then following that, she went to the Mayo Clinic and did 2 years of MS and CNS inflammatory fellowship. We were so lucky to be able to recruit her back to the University of Alberta, where she has joined us as one of our members of our divisional community. Now, what I've outlined seems like a fairly focused academic career. But in fact, those of you who know Nabeela know that her insatiable curiosity and energy has really sort of propelled her to examine many different things at many different times. Hence, her building of expertise in conditions such as CNS histiocytosis. And so that's what she's going to talk about today. Join me in welcoming Nabeela.
Thanks so much, Penny. So yeah, you might be wondering, why is a neurologist talking about this? And so a lot of this kind of stems from my fellowship training. So my fellowship director at Mayo Clinic was actually an expert in neurological manifestations of histiocytosis. There was a Mayo Clinic histiocytosis working group. And so whenever you did clinic with him, you would get MS and related disorders and all these random cases of histiocytosis. And I remember when I started fellowship, he kind of asked me, he said, do you want to do some research in this area? And I said, not really. But then I would do clinic with him and we would see these cases of histiocytosis. And I was so frustrated because I didn't have an approach to these cases at all. And so within kind of the first year of starting my fellowship, he asked me again, he said, do you want to do a research project in this? And eventually I said yes, because I was just so irritated by my lack of knowledge and lack of approach to this that this has now led to kind of an additional interest and passion of mine that I have thankfully been able to carry back to U of A, in part because Meenakshi Taparia has very kindly let me follow the cases of histiocytosis with her that have neurological involvement. So I can push through the land acknowledgement because thankfully Penny's already done that. Those are my disclosures, none of which are relevant to this talk. So the objectives that had been listed are for the audience to gain an understanding of the diversity of presentations, kind of the 3 most common types of histiocytosis, which includes Erdheim-Chester disease, Langer-Haunt cell histiocytosis, and Rosai-Dorfman disease. And then as a non-hematologist, to provide you with, I think, what is sort of a practical approach to workup for a potential histiocytic neoplasm. So this is very clinically oriented, I will say. So I'm going to present a case and I'm going to go through it in the way that the case was given to me. So it's not going to look clean because these things are not clean when they come to you to begin with. So I was on call for neurology consult service, taking calls, and I was called on I remember it's always a Friday afternoon call that you get for this stuff. So I was called by a colleague in endocrinology about a 58-year-old man who had been followed for a greater than 10-year history of central diabetes insipidus and hypogonadotropic hypogonadism, and he had an unintentional 25-pound weight loss. He was found to have some axillary lymphadenopathy, and then she said there was some more recent onset of neurological symptoms, which, for what she could gather, was some gait unsteadiness and maybe some kind of shock-like sensation in the face. At the time that she called me, he'd already had a CT of the chest, abdomen, and pelvis for lymphadenopathy, and I'm just putting in like kind of the relevant things in quotation marks that were part of the report. So they had seen some infiltrative soft tissue in the renal hyla, perirenal. They had queried things like lymphoma, IgG4 disease, or atypical infection. There was some involvement of the lungs with some nodules, some perilymphatic distribution. There was a heterogeneous thyroid. And then they mentioned no significant lymphadenopathy and then no aggressive bony lesion. Because of this, he had already undergone a bronchoscopy. And this was the initial report where some scattered lymphocytes, some vacuolated histiocytes, which you can read histiocytes in lots of pathology reports for, which are kind of deemed to be non-specific, if you will. And then negative for granulomatous inflammation or lymphoproliferative disorders. I think there had been a discussion about kind of the renal disease, and at that time there was a concern that this could be lymphoma, talking to colleagues from other specialties. The patient himself got a private brain MRI, and I've just kind of picked relevant cuts here. So I will say at the time that I was called, I didn't have access to the images, I just had access to the report. So axial cuts you can see on FLAIR, there's it looks bad, right? Like you don't have to be a neurologist to see that there's a lot of abnormality here. So hyperintensity throughout the brainstem, and then a lot of these are gadolinium enhancing, kind of globular looking. It doesn't look good, okay? So I'm worried. So I book an extra clinic and I see him. I get the call on Friday. I book him in on a Monday. And I have Arth Powell with me, a phenomenal PGY5, just doesn't know what clinic he's coming to do. He thinks he's coming to do a lumbar puncture clinic. And then I say, oh, by the way, I've slotted in this patient. And so we get a very thorough history and physical exam. So this is a summary. His note is essentially a novella. As he said, it's actually true. So to summarize all the symptoms, right, he's had this electric shock-like sensation in the left side of his face. It's not clearly brought on by innocuous stimuli, and that had been for 16 months, so thinking of a trigeminal neuropathy. He's had progressive balance difficulties for 6 months, dysmetria, truncal ataxia. He can't sit and actually drink a cup of coffee anymore, and that's been for 2 months. He's had progressive weakness and muscle atrophy, proximal greater than distal, and then his family's very clear that he's had these emotional fluctuations many times per day that had started about 6 months ago. It's described as crying inappropriately. He's had progressive dysarthria and dysphagia for 6 months, and he'd had to stop working due to those symptoms for 4 weeks prior. And then they say, oh yeah, because we ask on this review systems, we say, any skin changes? And they say, yeah, he's had these kind of red lesions in his armpits, and he's actually been prescribed a topical steroid for these. So in terms of the exam, so shockingly, neurologists sometimes have to do a skin exam, not just for neurofibromatosis and things like that. So he had these periorbital bilateral xanthal asthma-like lesions, and his wife and son were in the room. And so I remember asking his son, like, are these new? Have these been here for a long time? And he said, no, these are actually new within the past year. So we pulled up photos and compared them, and we're like, yeah, these are definitely things that weren't there before. And we have him in a gown, because if you do clinic with me, you put everybody in a gown. And so he had these lesions in his axilla that we looked at as well. And these were small and red and macular, not pruritic, not painful to touch. And these were what he had been given topical steroids for. And then going on to the neurological exam that we actually know how to do. So lots of findings. So gaze about direction changing nystagmus. For the neurology people, he had a Bruns nystagmus, which had come up in kind of case rounds for anybody that was there prior when Gurpreet had presented this case. He has bifacial weakness, dysarthria, has some mild left shoulder abduction weakness, left hyperreflexia with an upgoing plantar, and then he's very ataxic, both axial and appendicular. And then he's crying throughout this evaluation, like every 5 minutes, basically in keeping with pseudobulbar affect. So we see him in clinic. It takes like half the day to try to get all of this together, really. And thankfully, we have colleagues in neurology that are willing to admit this patient to hospital. So we basically call and say, can we please admit this person and get an expedited workup? I'll say by this point, I already broached histiocytosis with them based on experience and kind of seeing these findings. So thankfully, one of our colleagues, Dr. Shetty, had accepted this patient to be admitted to neurology. And I said, can I just tell you all the tests I want to do? And he said, yes. And that worked out beautifully. So, so they did do a CSF examination that was bland. We sent for kind of testing for hypothalamic pituitary dysfunction. So you can see kind of the panel with FSH, LH, IGF, prolactin. That was all abnormal. Notably, these tests had been done by his endocrinologist a few months prior, and they were normal at that time because it was followed by endo for the DI and whatnot. And so they had, and in fact, they'd already even done an MRI in 2018 to look at the pituitary and hadn't found anything abnormal at that time, okay? So as will kind of come up as like a theme of the talk, because I'm really not an expert in histiocytosis in general, I would say. We biopsied everything we could biopsy. So, and that's kind of what you have to do in these cases. So the skin lesions are easy access. We had those biopsied, in dermatology, thankfully was, engaged and very willing to help. So we had biopsies of the xanthelasma-like lesion at the eye. He had a biopsy of the right axilla. And then we also got biopsy of the perinephric area that had been noted to be abnormal. And with all of this, I actually had to call pathology and say, these are the exact stains I want done. Because in general, these are not stains that are done as part of the standard panel when you ask for pathology for anything. So, and actually in Art's note, we put down also the specific stains we wanted to guide everybody. But these are things that you have to, so basically it was a day of like making a lot of phone calls. And I ended up calling pathology also to go over the bronchoscopy tissue and to see if any of these stains were positive, which they were not. So kind of with communicating with multiple services, I kind of highlighted the aspects, and this will make more sense as I go through the talk, but the xanthelasma-like lesion had xanthomatous histiocytes. They were positive for CD68, and then stains specifically for Langerhans cell were negative. And then this BRAF V600E stain was negative. For the skin punch biopsy at the right armpit, there was positivity for S100, CD68K, and CD1A, and this would be more in keeping with Langerhans cell histiocytosis. And then this BRAF V600E stain was positive in the melanocytes. And then they had to actually go back and reanalyze and get a pathology consult for the perinephric tissue because it wasn't really specific at the time. They just mentioned these benign foamy histiocytes. And then when they went back and looked again and did kind of the specific stains we asked for, there was CD68 positivity in keeping with Erdheim-Chester disease. So you're like, what are all these things? We'll get there. Shortly after discharge from hospital, so he was admitted for, I think, under a week. And then we ended up getting everything else kind of expedited as an outpatient. So his PET body was floridly abnormal, unsurprisingly. So there was hypermetabolism in the perinephric areas with perinephric stranding. All these words mean something, so it's useful that they were included. The other thing that was interesting was there was hypermetabolic involvement of the thyroid, but his thyroid testing for TSH T3, T4 was all normal. So there was a question of whether this could be infiltrative pathology. And then they say features are not entirely specific, but obviously could be seen in systemic histiocytosis such as Erdheim-Chester. And for the PET scan, we had to ask, so a normal PET scan will just be kind of calbarium to mid-thigh. You have to ask for it to be vertex to toe because you need to encompass the long bones that can have, can be involved if you have Erdheim-Chester disease or Langerhans. Also, I actually had to call the nuclear medicine physician and ask them, is this vertex to toe? And he said, no. I said, can you make it vertex to toe? And he said, why? And I said, well, I'm looking for Erdheim-Chester disease, any of these things, they need long bone involvement. And he said, you're the first person that's called me in 25 years of me doing this to tell me what needs to be protocoled. But he did it for what it's worth. And there was no long bone involvement, but that's also very useful to know. And then he did end up getting his thyroid biopsied, and that was consistent with Langerhans cell histiocytosis. So that would make sense with infiltrative pathology being a histiocytic neoplasm. So with the help of actually Dr. Taparia, we reached out to pathology. I think I'm a neurologist, so maybe there's a bit of reluctance initially to send for next generation sequencing. But we were able to get next generation sequencing, and we did identify a BRAF mutation, not B600E, that's the most common one, but a different BRAF mutation. So diagnosis, in summary, was a mixed histiocytosis. So he has both features of Erdheim-Chester disease and Langerhans cell histiocytosis. He was initiated on a BRAF inhibitor. So this is the part where I kind of step out and let hematology take over, but he was on vemurafenib. You can get a skin rash, honestly, with normal doses, but for him, it happened at a higher dose. He's quite early, so a couple of months into treatment, we saw him in clinic and follow-up. He has had improvement in his dysphagia, dysarthria, and his pseudobulbar affect. His MRI brain at this point, unfortunately, doesn't show a significant change, but his PET body does show a significant partial response for his kidneys and his thyroid. So at this point, we're still early, like he's a new case for me. We may add in cobimetinib, which is a MEK inhibitor, depending on the next MRI brain and PET body. So what in the world is histiocytosis, right? Okay, this was my question forever and ever. So So it's just this abnormal accumulation of monocyte-derived dendritic cells or macrophages. So if you have an accumulation of these cells, these are an immune cell subset. And so this looks like an inflammatory disease, but it's an inflammatory myeloid neoplastic disorder. And so the three most common types are the ones that had been mentioned. So Erdheim-Chester disease, Langerhans-Cell histiocytosis, and Rosai-Dorfman disease. Most have mutations involving the mitogen activated protein kinase or MAPK-ERK pathway, and about 50% with Langerhans-Cell or Erdheim-Chester have this BRAF V600E mutation, and that matters because of the targetable therapies with the vemurafenib. I'm not going to talk about HLH because that's more of an immune dysregulation syndrome rather than kind of one of these proliferative disorders. Altogether, just from looking this up, mixed histiocytosis is quite rare, so there are fewer than 200 cases of this combo that have been reported in the literature to date. So as a simple neurologist, I'll just say that in this kind of MAP kinase signaling cascade, your activating mutations tend to be mostly in this BRAF area. And this leads to basically activation of this pathway. So you get uncontrolled cell proliferation and survival. And so the goal is to kind of curb that. So you can have mutations in any of these, to be honest. So I have somebody with Rosai-Dorfman who has a KRAS mutation, but BRAF would be the most common. So in terms of Erdheim-Chester disease, this mostly affects adults. There are about 1,500 cases reported worldwide. And the way you kind of characterize the disease is based on the number of lesions and organ systems involved. So you can have a single lesion, single system. So single system could be neurological, but you could have multiple sites within the neural axis involved. Multifocal, which could be single system or multi-system. And then, I found these reviews to be very, very helpful in terms of outlining all of the other areas that can be involved. So you can have orbital masses, and kind of the orbital involvement of histiocytosis has been kind of with a series that's been well described by colleagues of mine at Mayo. In terms of neuro involvement, you can have dural involvement, but really more often than not, we see parenchymal involvement, which can include brain and spine. And then you can also have nerve root involvement, particularly in one subtype of Erdheim-Chester disease that is seen. In terms of the dermatological involvement, you can get these anthelasma-like lesions, so it's important, and you can see them in the clinic, so it's worth looking for these if there's ever a question, and it's also an easy biopsy site. In terms of endocrinopathies, you can have diabetes insipidus, which, as it says here, often precedes the diagnosis, and you can have hypothalamic pituitary lesions, but you can also have hypothalamic pituitary dysfunction in the absence of any imaging abnormalities, so it's worth screening for regardless. If people have BRAF V600E, they can have cardiac involvement, which can include aortic and pericardial infiltration. In terms of the retroperitoneum, this is where his findings were relevant. So he has perinephric involvement. And once I read that, that kind of flags you to think about this diagnosis. And you can have something called hairy kidney, which will come up on the next slide. And then often you'll have these osteosclerotic bony lesions, and they're pathognomonic, but you don't have to have them in order to have the diagnosis of Erdheim-Chester disease. So in terms of other manifestations, these can be these anthelasma-like lesions. In terms of the hairy kidney, you see kind of this wispy stuff that's around. This would be deemed the hairy kidney. And then you can also have aortic involvement. So in terms of neurological things, because I'm a neurologist, I'm obviously going to go there, and I have enough neurology people here. Parenchymal posterior fossa involvement is common, and he had kind of the symptoms that would be in keeping with that. And you look at these scans and they look terrible, right? And so that you can have these mass-like lesions. And some of these have been misdiagnosed. So one of the cases we had been initially misdiagnosed as diffuse intrinsic pontine glioma, DIPG. You can have intramedullary spinal cord involvement, so they'll have features of a myelopathy. And then, as I mentioned, you can have hypothalamic pituitary dysfunction, even with normal seeming pituitary hypothalamus on imaging. And if you have a CSF1R mutation with Erdheim-Chester, you can have lumbar nerve root involvement. For Langerhans-Cell, in the literature, this is most often described in pediatrics, but we have a lot of cases in adult too. And in terms of the characterization, it's very similar to Erdheim-Chester, where it's dependent on how many systems are involved and kind of how many lesions you have. In terms of systems involved here, again, diabetes insipidus, you can have dural lesions, which will be extended from the calvarium. Also can have bony lesions. They often have respiratory involvement. And the one thing that I think I remember learning in medical school was smoking was a risk factor for having pulmonary Langerhans cell histiocytosis. So that's kind of the one thing to keep in mind here. And then they can have dermatological manifestations as well. More rarely, these anaplasma-like lesions, more often than not, they'll have a papular rash. Bone and skin are most commonly affected for Langerhans cell histiocytosis. So they can have these kind of scaly rashes, they can have calvarial involvement, they can have kind of multiple areas of bone involved, and they can have a lymphadenopathy, they can have these pulmonary nodules. And then bit debated, I would say, but in terms of neuro, there is description of Langerhans cell associated neurodegeneration. So you can see bilateral dentate nucleus hyperintensity. There was a study that came out just last week, actually, from Mayo, kind of going through these cases. And in terms of the neurodegeneration, so they'll have kind of more of a progressive ataxic syndrome. One of the things they notice, though, is that many of those people just have active, untreated histiocytosis rather than having an actual degenerative disease. And so, at least in their paper, they saw a minority of cases have this neurodegenerative phenotype that is typically associated with pontocerebellar atrophy. In terms of neurological manifestations, you can have dural involvement, as was kind of mentioned in the last slide. You can have posterior fossa involvement that looks similar to Erdheim-Chester with these mass-like lesions, and then they often also have hypothalamic pituitary dysfunction. So Rosai-Dorfman, I didn't go, it's not in this case, so I am following somebody with Rosai-Dorfman at this time, but the previous term was sinus histiocytosis with massive lymphadenopathy. So basically, they just have painless, very enlarged cervical lymph nodes. These can spontaneously resolve. The presentation is more variable than Erdheim-Chester and Langerhans cell. So typically we'll have dural based lesions. As mentioned, they're going to have a lymphadenopathy. You can still have retroperitoneal involvement. They have a little less bony involvement, and there are kind of these familial forms of Rosai-Dorfman. I haven't seen any of these specifically yet, but they do exist. So in terms of neurological involvement, these were interesting to review, actually, because these people can just be diagnosed with having a meningioma. And so they can come in with kind of the symptoms you would expect with, if you have a hemispheric meningioma, they could have seizure, they can have weakness, they can have headache. And until they're, maybe these are removed and they look at the histopathology and see, oh, it's actually not a meningioma, it's actually histiocytic neoplasm. Rarely they can have spinal cord involvement as well. In terms of treatment, again, I'm not a hematologist, but having seen enough of these, really we're trying to target these pathways in the MAP kinase pathway. So if you have a BRAF mutation, we'll often start with vemurafenib. And then if you don't have a BRAF mutation, so as I mentioned, our patient had next generation sequencing done. He had a specific BRAF mutation. If they don't have this, you can go to one of these kind of less specific MAP kinase inhibitors, which includes cobimetinib, and that tends to be the one we pick the most. So I think this will probably be the most important slide from my end from a teaching standpoint. So as a neurologist, clinical suspicion for me for a histiocytic, because you're like, why did you think about this? Well, the suspicion will arise as a neurologist if somebody is coming in with persistent gadolinium enhancement for longer than 3 months. And these cases often come in with a lack of response to immunosuppression. So they don't respond to steroids. They don't respond to MS treatments. And I didn't present this case for the purposes of this presentation to medicine, but one of the cases that we saw when I was a fellow was somebody who'd had progressive neurologic dysfunction for 18 years and had been misdiagnosed with primary progressive multiple sclerosis. And that was in part because his mom had that. And he was put on every immunosuppressive drug I could think of. And he didn't respond to any of them because the inflammatory part of this disease is related to the fact that it's hyperproliferation of an immune cell subtype. It's a neoplasm. So lack of response to immunosuppression is very, very important here, which also helps you differentiate it from things like sarcoidosis and lymphoma, right? And then you have multisystem disease with features that we've gone through in the previous slides. So if I have any clinical suspicion, this is what we do. So PET body vertex to toe, because you want to look for long bone involvement. a skeletal survey to look for additional bony involvement in case it's going to be missed on the PET. And then you have to biopsy as many amenable sites as possible because, as you saw in the case that I presented, the bronchoscopy actually didn't help us confirm the diagnosis. We needed skin and we needed kidney and we needed thyroid to kind of come together. And the type of histiocytosis was different depending on the tissue that was biopsied. So you can have these cases of mixed histiocytosis as well, which is kind of important to know. I always refer people to dermatology for a skin check, as they could find a site to biopsy that can help clinch the diagnosis. And you have to be able to say enough kind of in the history of why you're concerned about this. You should connect with pathology colleagues to ask specifically for certain stains for histiocytosis, which will come up in one of the later slides, but you don't have to know, but it's good to know that that is a connection point that you need to make in order for you to actually be able to assess adequately if somebody might have pathology that fits with histiocytosis. And then to work with your hematology colleagues and pathology colleagues to send for next generation sequencing, because you might find a specific genetic mutation that can guide your treatment decision. So this has been kind of put together by a colleague at Mayo on a diagnostic approach for possible CNS histiocytosis. I think it still applies for systemic. So smattering of blood tests, which includes looking for hypothalamic pituitary dysfunction, MRI of the whole neural axis, full body PET, again, vertex to toe, and then biopsy lesional tissue. For the neurologist, which I'll get into kind of in the last part of the talk, you're looking for a systemic area to biopsy. I don't want to biopsy the CNS. Well, I'm not going to biopsy, but I don't want neurosurgery to have to consider biopsying the CNS if we don't have to. If you don't find something, then you may have to go there. And then to send for BRAF V600E testing. The one comment I'll make actually in terms of the testing is we don't have the option to send plasma cell-free DNA. They have to do immunohistochemistry on a biopsied sample and then send for next generation sequencing. So Mayo, we could send for urine, and plasma, we can't do that here. Send for next gen sequencing and then kind of confirm the diagnosis. And I'll say, at the time we saw this patient in clinic, I'd already had a clinical suspicion. One of the first things I did was reach out to Meenakshi Taparia and say, hey, this is the case. What do I do? And in order to get to this diagnosis, we had neuro, endocrinology, hematology, pathology, dermatology, like lots of specialties involved to try to make this happen. And so I think to connect with people early is really, really important here. These are some of the recommended stains. Again, I'm not an expert, but you can see that some of these columns have pluses and some have minuses. And so you can use these stains to differentiate between the different types of histiocytic neoplasm. So Erdheim-Chester will often have CD68, 163, these factors, and then they're negative for CD1A and Langerhans because those are specific for Langerhans cell histiocytosis. And then BRAF mutations by definition do not really exist in Rosai-Dorfman, but you should be looking for them in situations where we're wondering about Langerhans cell or Erdheim-Chester. So even if you don't know them, you don't have to know them, but I think it was helpful to list them to say these are the things that we would like done. And our pathology colleagues have gotten interested in this, I think, after we worked through this last case together to say, oh, we can stain for these things. We're happy to be involved. And they were really instrumental in helping us get to a diagnosis. So again, I'm a neurologist. I mentioned that I had mentioned that my fellowship director had broached doing a research project with me, and I said no. And then eventually I came around the right way and said yes. And so the question that he had wanted to answer was, how common is isolated nervous system involvement at initial presentations for cases of histiocytic neoplasm? And so for this, we looked between 1996 and February 2023. So you had to have a histiocytic neoplasm based on a nervous system tissue biopsy because it's a primary nervous system presentation. So lots of areas were biopsied. This is a kind of a Mayo series, so they were a bit aggressive, I would say, in biopsying, but it was helpful to get diagnoses. And they needed to have isolated nervous system involvement with other organ systems being involved. So PET body needed to be negative, or CT chest abdo-pelvis along with a nuclear bone scan if that was available. So with that, we had like 377 cases of just histiocytosis that had been seen at Mayo Clinic. And among those, 5% had isolated nervous system involvement, 3% with Langerhans cell, 7% with Erdheim-Chester, and then 13% with Rosai-Dorfman. body, kind of full body PET was done in the majority of those people, and then a smaller number had just a bone scan and a CT chest abdo-pelvis. And then looking kind of longer term, over 80% of those people had sustained isolated nervous system involvement. The people that ended up getting systemic involvement, 2 of those with Erdheim-Chester developed systemic involvement 5 months later. So one had bone, and then one had lymphadenopathy, and then one with Langerhans had cutaneous involvement actually several years later. These are some of the demographics, and I think the main things I want to actually point out is that the time to diagnosis was quite fast with Rosai-Dorfman, which I think is mostly because they have a dural-based lesion. As that thing has grown to a certain kind of critical size, they come in symptomatic, they get worked up and kind of diagnosed right away. Whereas Langerhans takes longer, and I think that's because they just have, they'll come in with some central DI, they'll have some hypogonadotropic hypogonadism, they're doing fine, they're being treated, and they may not manifest with other things right away, and so they don't get diagnosed as quickly. In terms of kind of neurological manifestations, just a few things I think to point out. So really, diabetes insipidus is essentially in everybody with Langerhans. We can have quite a bit of ataxia with Erdheim-Chester, and that will likely relate to the posterior fossa involvement. There's a bit of cognitive impairment, but it's not really a prominent feature in the cases that we had. And you can also see kind of a smattering of cranial neuropathy. I think the imaging findings are more interesting. So everybody had abnormal enhancement, right? And this is the thing, they had abnormal enhancement for a long time. And then in our series, most of the people did have hypothalamic pituitary abnormalities on imaging, but like I said, that's not necessary to have biochemical dysfunction. And then spinal nerve root involvement can be seen with Erdheim-Chester. We don't really see it with the other types of histiocytosis, and many of these people have mass effect. In terms of outcomes, so just as it says down here, PD means progressive disease, SD is stable disease, PR is partial response, CR is complete response. Variable with Langerhans, really we find that people with Erdheim-Chester disease don't do so well. We did have somebody with the same BRAF mutation that we have in the patient that I presented, and that person ended up going on a MEK inhibitor and had partial response, which is why I think part of the reason we're considering adding that in for the patient that we're following. And you can see all these mutations that are found. So it's, I mentioned BRAF V600E is the most common, but next generation sequencing will identify many of these other ones, which are important to help you get to diagnosis and for management. Rosai-Dorfman is interesting. So most people just needed surgery. So they have a dural mass, the mass is taken out, and they tend to do okay. So very different outcomes between all these different types, and so important to know which one you're dealing with. Because this was new for me and presumably reasonably new for most of you, there are some very nice resources out there. So for patients, there's a Histiocytosis Association of Canada and the Histiocytosis Association. They have really lovely resources there. And then for anybody who's had their interest really piqued with this talk, there was a Histiocyte Society conference, which I went to a few years ago and presented at. It was quite nice because it's not a huge community of people. There's a nice mix of adult and pediatric. And it was a really nice venue to be able to present work and learn from others. And then there is an Erdheim-Chester Disease Global Alliance, which has an annual conference, and both patients and providers tend to go to the Erdheim-Chester Disease Global Alliance meeting. So to summarize, histiocytic neoplasms can present with isolated nervous system involvement in about 5% of cases. Like I said, I think persistent gadolinium enhancement and lack of response to immunosuppression should raise consideration of this diagnosis as we're thinking about other things like sarcoidosis and lymphoma, which typically do respond to steroids. If there is a clinical suspicion, the investigations, as you can see, are quite broad to look for systemic involvement and to biopsy multiple sites to confirm diagnosis. And this required so many specialties of medicine, but we were able to get to a diagnosis, and we do have treatments to offer them, so we shouldn't miss actually trying to get to diagnose these people. Happy to take questions. Thank you.
Well, we do have a question right away. Richard.
So two questions. So this is like always been, I worry about those cerebellar
Yeah.
stem lesions. So the picture is classic, and So the question is, why does it go there?
Mm,
I have another question.
I don't actually know the answer to that. Good question. Don't know.
Again, the differential with lymphoma and.
Yeah.
And
Yeah, there must be something within the molecular aspect that I don't know enough about to be able to answer that question, but truthfully, but yeah, there is a predilection, right? Like Rosai-Dorfman doesn't really go to the brainstem, but Erdheim, Chester, and Langerhans will do. I don't know.
The other question I had was, you said there were also mutations in CSF1R.
Mm-hmm.
So that's interesting. So that you get, the disease that you get with CSF1R mutations,
Mhm.
kind of the neurodegenerative axonal spheroid
Yes.
disease.
Yeah.
We've seen a couple of cases
Yeah.
of that, and so I'm always worried about missing that, right?
Yeah. Yeah, and they're not related. It's confusing.
Is
Yeah.
there any overlap?
Not that I know of. No, I wondered the same thing when they said CSF1R. I was like, but we see that for this other thing that we also see these
Which
rare
also
cases of.
includes the
Yes, it does.
Preferably.
Yeah, no. So the CSF1R for the histiocytosis cases tend to just have lumbar nerve root, and that's where it goes. And so we've had to biopsy that to confirm diagnosis. And their management is different because they also have a different targeted treatment which is I think pexidartinib or something like that. So totally different entities, also with the term of CSF1R. Yeah.
And Nathan.
Lovely talk. I always learn something from you guys, in clinics, so, that's a little bit different. I'm very curious about these, these primary CNS
Yeah.
manifestations, right? And these probably remain difficult, especially in somebody that has vision. Nobody's really. So my question is, in these cases, is it helpful to then pursue something like a bone marrow biopsy as a kind of a new plastic logic?
Yeah, good question. I think unless you have an imaging abnormality, less useful. Yeah, that's so. I mean, and this is why we get so aggressive trying to look for things systemically. So before I even go for trying to get a CNS biopsy or to go for a bone marrow, we try to get very we discuss a lot with the dermatology to try to biopsy anything and to send for the staining. But yeah, in the CNS primary cases, they did, and a bunch of them had brainstem biopsies done. Yeah, tough ones. I know. Yeah.
Quick question about treatment. I know you don't give a lot of treatment.
No, that's okay. Yeah.
Like, what's the expectation for these patients long term? Like, are
Oh,
they
yeah.
supposed to be cured? Do they just feel a little bit better, or is it?
Yeah, this I can actually answer. So I don't have to manage all the side effects of treatment, which is very nice for me. They don't tend to fully recover. So the morbidity for these patients is quite high. They'll have some improvement. Really, the goal is stabilization of disease, and especially in these cases when you have such a delay to diagnosis, I think this becomes difficult because they've progressed so far along with an active process that it's hard to come back from that. I haven't really seen in practice. So I think I'd say I've seen about 15 in the range of 15 to 20 cases in like the last 3.5 years. And I have really not seen full recovery in most. The people with Rosai-Dorfman tend to do reasonably well. I think that would be the one, but people with Erdheim-Chester disease, I have not seen great outcomes for. So even the patient that I'm following, the first discussion was treatment will be started. I expect some improvement. I don't expect him to fully recover.
I was trying to think of what I would do if I didn't have you around as a neurologist, approaching some of these cases. And I've had one Langerhans that I know of in my career, and it came up actually through kind of a biopsy of a lesion that was infiltrative from the skull into actually the brainstem kind of area. So we managed to go along like that and muddle our way through to the correct diagnosis for her. But again, persistent enhancement. Yeah. But so I was thinking, what could I do? I mean, there's some takeaways I had from that, like the PET doing the whole body is really, really helpful. The biopsies, I think I can handle the CNS, like the MRI findings and that kind of thing involving hematology. I would probably, though, in my discussions with pathology, just ask them to stain their
Yeah.
histiocytosis.
Yeah, you can. Yeah, you don't have to
rather
do what we
than
did.
give
Yeah.
them specific.
I think there was a bit of confusion. They're like, but what do you want? And we said, well, these are the stains we want done. I think that's fair. And the way I think part of the reason I found these interesting is because as somebody training in neuroinflammatory, we have these undifferentiated neuroinflammatory diseases, and the approach is reasonably similar.
Yeah.
Right? Like you're looking for a systemic site to biopsy, so you want to do a full body scan. We'll look for for skin lesions in some of these situations. Often we send to ophthalmology. If they have an orbital mass, it would be very useful to do that. But in these cases, they none of them had this. So I think it's really just I think, I think it's just widespread testing and then getting colleagues involved, particularly from hematology and pathology, to say, this is what we're worried about for these reasons. Can you just help us look for this? Yes, I did. I think I see one's a question. So one of the questions is, how often is CSF abnormal? Yeah, good question. I actually didn't go into that. So you can have a bit of elevated protein and you don't really have much in the way of high numbers of lymphocytes. And so we do the LP really to rule out other things, I would say, to, send for testing for lymphoma and things like that, to send a high volume CSF. But in terms of histiocytosis, you don't really have much that's telling in the CSF. And so I would probably just go for tissue biopsy rather than getting a CSF in these circumstances. Oh,
There's another section.
oh, look at that. Okay, so sorry. Okay. Okay, these are classic insidious multisystem diseases like vasculitides. Yes, where diagnosis can take a while. Can I expand on differential? Really, so I'll speak to neuro because that's easiest, Bill. So really the three things, and this was kind of how I was trained, so I'm coming in with some bias here. The training was, if you have persistent gadolinium enhancement, three things: sarcoid, lymphoma, histiocytosis, nothing else really. That's what we were taught. And so that is the differential I sit with in these cases. And the way I shift more to histio is if they don't respond to steroids. That's really the big thing. Chris Power is asking, are there distinctive molecular profiles in the different histiocytosis inflammatory response? Probably, but I don't know, Chris. That's beyond me. I actually don't know the answer to that. And Aaron Miller's asking, does our center have much experience with primary CNS histiocytic sarcoma? I don't follow anybody with that. I kept out the sarcomas specifically for this talk because I think they're rarer and very difficult to manage. So maybe Meenakshi Taparia would know the answer to that, but I don't. And I don't know any of our colleagues that are following these patients. And I'm trying to take over as many of the histiocytosis cases from my colleagues as possible. We don't have any at this point in time that I know of.
There's another pearl you threw in there, though, which is that a little trial of steroids really helps.
Yes. And it's true. And this is when we get these people, right? So we're like, well, let's just try some steroids. And then they don't respond.
Yeah.
Thanks for that Q&A thing. Oh, wait, maybe there's more. Let me see. Wait.
Or inflammatory.
Oh, it just says open. Okay.
Oh, we have a question at the back there.
Oh, hi. Go for it. Hey.
Exciting case. So did this patient present first with the endocrine
Yes.
issues?
Yes.
Diabetes.
Yes.
And so did they have pituitary mass?
No. No, and this is exactly the point. So the endocrinologist who follows him appropriately did an MRI to look at the pituitary. There was nothing abnormal. And in our experience clinically, neurologically, they don't always have pituitary hypothalamic abnormalities on the scans, but they can have dysfunction. So even in his case, he didn't have pituitary hypothalamic abnormalities on his MRIs. It's all brainstem, but he has clear kind of biochemical abnormalities involving pituitary hypothalamic.
Do you think
axis.
this might be at such a microscopic level that we're just not appreciating?
Yeah, I think so. But yeah, as you said, I don't think our imaging is high res enough to be able to do that. If somebody did a research MRI with some special sequences, actually that's a very good research idea. They could find something, and it's a rare disease, so we don't bother to look. This has given me ideas. Thank you. But they really didn't have imaging abnormalities.
Like with the pets or galley of different shoots like that.
Oh, I have to go back and check that.
This-
It did, but the thyroid was like is like a mass-like thing in there, right? And so what I'll say I think is on MRI we won't see kind of specific evidence. I'll check the PET part and then I'll send you an email because I'll double check that for myself too because it's good for me to know. Yeah.
Like,
Yes.
we always learn about histiocytosis.
Yeah.
This is the first time I actually see it.
Mm-hmm. Mm-hmm.
Oh, we'll call Nabeela.
Yeah, I mean, I really enjoy these cases. I think they're challenging, but they're kind of algorithmic, and you get to work with a lot of specialties, and it's very rewarding to get to a diagnosis for people that have been waiting to hear one for years, and to be able to treat it, right? So
Like did his neurologic symptoms improve?
he's a bit better. I mean, it's very early, so he started drug in September. I saw him in November. So from some of the standpoint, he's a little bit better. So he's a bit better from his swallowing, his speech, his pseudobulbar affect. Like he wasn't crying every 5 minutes. He was crying like once every 20 minutes.
Oh, that's so much better.
It was a lot better.
Give him a little
It
bit
was
of
a
an
lot better. I was like,
SSRI.
wow. I was like, this is so much better. So it's a bit better, but the neuro, and I think part of the reason I'm interested as a neurologist because the neuro disease is notoriously hard to treat. So systemically, they'll get better. And so I've been kind of brought in cases across the country from, like, I had a message from somebody at UBC who has systemic histiocytosis with neuroinvolvement. They put them on drug. The drug has totally cleared the systemic disease, but the neurological disease is very, very hard to treat. And so I think that will be the last thing that improves for him.
Do the agents have CNS penetrance?
Great question. This is part of the reason we're considering doing a combo with the BRAF and the MEC. Yeah, to improve the CNS penetration. Yeah. Yes,
Oh,
Richard.
Another question.
Okay, so do they actually not get better with the steroids, or they get worse?
They don't. They just don't get better.
Because the Mayo series on the neuroaxonal dystrophy,
Yeah.
the axonal spheroids,
Right.
they actually had our case got worse on
Okay.
steroids. And
Yeah.
thinking of it, and they actually have their like case series of 6 and we had 2, so we didn't bother, right? We wrote up the chapter, but
Yeah.
in our case got worse, and they had a case, one of their cases got worse. Yeah.
They don't tend to get worse. They just don't get better. Yeah.
And the other thing we used to do before you were here, Mayo people are a lot of Canadians there.
Mhm.
Call
Mm-hmm.
they're very open.
Mm-hmm.
Yeah.
Yeah.
I mean, now we don't have.
Yeah, so I'm still connected to them. So they said, well, if you have difficult cases, like my fellowship lectures, if you have difficult cases, you can peer in and present at our histiocytosis kind of seminars. But thankfully, I haven't had to do that yet.
Well, thank you so
Thanks.
much. That was great.
Thank-